So anyway, to introduce our speaker today, Jessica Ye is with us. She is conducting a clinical trial in metformin and behavioral change compared to controls as a member of the Cancer Center and an associate professor in general internal medicine in the School of Medicine. She has a joint appointment in epidemiology as well. So Jessica and Fred Brancati created a history of investigating cancer and diabetes, especially cancer incidence. So we welcome Jessica today to our Lunch Learn Link seminar.
So thank you for inviting me. It's an honor to be here and share the research I've been doing and I'm doing with this audience, and hopefully I'm hoping to receive feedback from you and for future studies. So I have no personal conflict of interest, and we do have a institutional conflict of interest with Healthway, which is a disease management company, has developed a commercial weight loss program based on the result of the POWER trial, which I'm going to mention today. And I'm supported by several federal government grants as well as a Maryland Cigarette Restitution Fund at Johns Hopkins. Diabetes and cancer is a big topic, and today I'm going to focus on 4 topics. Hopefully I can get through all of them. So first I will start with diabetes and cancer incidence and mortality. And there are a lot of studies conducted by our research at Hopkins, so I'm going to highlight those local studies as part of centennial celebration. And I'm going to talk about metformin and cancer, weight loss and cancer outcomes, and finally will be the SPIRIT trial. It's an ongoing randomized clinical trial in cancer survivors. So first of all, I want you to meet Mr. B. So Mr. B is a real person in a healthcare system. Mr. B is a 75 years old black man with chronic kidney disease and 25 years history of type 2 diabetes. He also has history of ischemic coronary artery disease, congestive heart failure, peripheral artery disease, mild dementia, and colon cancer. He was admitted to hospital 4 times in the last 6 months. So unfortunately, Mr. B is not alone. When we look at national representative samples using the National Health Interview Survey data, and we found in people with diabetes, about 11% of them also have a history of cancer, and versus about 9% of them of non-diabetes adult has history of cancer. In older population, age 65 and older, the percentage of cancer history is higher, 17% in people with diabetes and 16% in people without diabetes. And those data are only adjusted for age, so it's not for making any causal inference. Diabetes and cancer share several common risk factors and disease pathways. So include the non-modifiable risk factors include age, race, and genders. And modifiable risk factors are obesity, smoking, diet, physical activity, alcohol. And they also share common pathway. 2 of them are hyperinsulinemia, means the insulin is too high, and hyperglycemia, the glucose are too high. So this is a diagram showing the insulin pathways. So in the organ levels, the insulin is produced by pancreatic beta cell and goes to the circulations. And at the same time, liver produce IGF, insulin growth factors, and IGF, BP, insulin growth factor binding proteins. And they also go to the circulation, and both of them will be in the target tissue like tumor cells and have a reaction with potential tumor cells. And in this study published in JAMA in 2005 by Dr. Rachel Stolzenberg Solomon, so Johns Hopkins graduate, she reported a higher glucose level and higher insulin level associated with increased risk of pancreatic cancer in 29,000 male Finnish smoker, which is pretty specific. And so let's look at here is a glucose and risk of pancreatic cancer. So higher glucose quartile. So look at this one with the circle dot. So with the population with a longer follow-up. So higher glucose level associated with a higher hazard ratio of pancreatic cancer. Same times for the insulin, higher insulin quartiles associated with increased pancreatic cancer risk. Another study done by another Hopkins graduate, Dr. Sang-ha Ji, in Korea, and he used data from more than 1 million Korean men and women and look at the relationship between fasting glucose and risk of cancer death. And even in this relatively lean population with BMI in 20s, he saw a dose response type of relationship between fasting glucose and risk of cancer death. So it's one of the supporting evidence for the hyperglycemia pathway in a relationship. Couple years ago, Dr. Fred Brancati and I developed this conceptual framework for obesity, diabetes, cancer, and mortality. So obesity, diabetes, cancer, death. It's not perfect. There are problems, but I think it works so far. Before cancer, let's look at factors related to cancer development. So at the beginning, maybe unhealthy lifestyles will lead to insulin resistance, hyperinsulinemia, and lead to diabetes. The unhealthy lifestyle also lead to obesity, and obesity lead to cancers. But after cancer diagnosis, there are other factors will affect risk of mortality. So, for example, the unhealthy lifestyle risk factor will continue to affect the cancer prognosis. And there were also evidence suggesting obesity and diabetes related to delayed screening of cancer screenings. And for people with diabetes and with cancers, the care for their diabetes and other chronic disease also can lead to downstream infection like comorbid conditions, and that will affect the mortality risk. So remember Mr. B, the Mr. B's case is a typical example in this continuism. So how about diabetes and cancer risk? There are a lot of studies being done and meta-analysis being done to show diabetes associated with increased risk for cancer of pancreas, colorectal, liver, kidney, bladder, breast, endometrium, but negatively associated with prostate cancers. And although there are some histogeneity in meta-analysis between studies, but the magnitude of the association and direction of the association are pretty consistent across the studies. So diabetes is a risk factor for certain cancers. I'm going to highlight some studies from here. So this was a study conducted in Q2 population in Washington County, Maryland. And so in baseline, there were about 600 people with treated diabetes and about 17,000 people without diabetes. So compared to people without diabetes, people with diabetes were older, will have a higher BMI, more likely to ever smoke, and have a less education. So this shows the association between treated diabetes and cancer incidence after 17 years of follow-up. So we do see diabetes was associated with increased cancer incidence, especially in women with 33%, and also with the digestive cancer as a whole, 1.73, and very significant association with pancreatic cancers. and some significance with smoking-related cancers. This is a result for cancer mortality, very similar to cancer incidence. Elevated risk in overall cancer, significant association with digestive cancer, colorectal cancer, and pancreas cancers. And Dr. Corey Josh Yu, faculty here at Hopkins, was able to look further to quantify the association between HbA1c and cancer risk and cancer incidence and cancer mortality using the ERIC data. So what she found is among people in women without diabetes, the low and high A1C are associated with increased risk of cancer incidence, but the association were not significant in men or nor in diabetic women or diabetic men. And similar association for cancer mortalities. So again, in women without diabetes, the association is very strong. Low A1C may be related to anemia. That's other disease conditions related to mortality. But there was no significant association between men and women. So I think this shows interesting maybe a biological differences between men and women in terms of relationship between diabetes and cancer and insulin resistance. The whole area. This is a new study I want to talk about. It's also our co-author from Johns Hopkins. It's data from American Indians using Strong Heart study. Strong Heart study is a cohort of 4,000 American Indians being followed for 20 years. And in this study, they found diabetes at baseline is associated with increased risk of gastric, liver, and prostate cancer mortality. And in American Indian population, in the Strong Heart study, they also exposed to high level of arsenic in the environment. So this study uniquely adjusts for arsenic exposure, and after adjustment, it shows increased risk of all-cause cancer mortality with diabetes. And in the subgroup analysis, they show insulin resistance among participants without diabetes at baseline was associated with liver cancer mortality with a hazard ratio more than 4. Okay, so this was analysis done by one of the fellow in general internal medicine, and he did this analysis with me using the SEER Medicare data, and he was interested in like a racial disparity and colorectal cancer survivals. So we analyzed the data from SEER Medicare 2000 to 2005 and compare black and white by diabetes status. So in people with diabetes and without diabetes, compared to white, black have a higher cancer stage, high proportion with a high cancer stage or unstage cancers. And so similar observation in people without diabetes. And in people with diabetes, we also found black were less likely to receive surgery and chemo treatment, and similar observation were found in non-diabetic group. So there was signals. It seems black are less likely to receive some sort of cancer treatment. And next question we look into is whether the disparity between black and white in terms of cancer mortality can be explained by any risk factors. So here in people with diabetes, compare black to white, the odds ratio for the hazard ratio for all-cause mortality is 1.21. But after we adjust for cancer stage and cancer grades, the disparity attenuated to null. So it suggests the cancer stage and cancer grade is a mediator of the disparity in people with diabetes. However, in people without diabetes, even after adjust for cancer treatment and comorbid conditions, the cancer disparity is still there, and we are not really sure what's other factors can explain this type of association. Maybe SEER Medicare data itself doesn't have enough information to explain other biological difference. So ADA, American Diabetes Association, American Cancer Society had a consensus panel back to 2010, and they made several recommendations, and these are two of them. So healthful diet, physical activity, and weight management should be prompted for all. And doctors should screen diabetic patients for cancer as recommended for all people in their age and sex. So I agree with them 200%. The problem is it's really hard to change behavior or to do a cancer screening, especially in minority population. However, difficult doesn't mean impossible, right? So our colleagues in Cancer Disparity Center recently published a result from their multi-year clinical trial called Cancer Prevention and Treatment Demonstration Screening Trial. And this program was to evaluate patient navigation as a strategy to reduce ethnic and racial disparity in cancer screening. And this paper shows a result in colorectal cancer screening. So compared with controls, the intervention group was more likely to report being up to date with colon cancer screening at the exit interview. And patient navigator increased screening for colorectal cancers, but not FOBT screenings. And a separate paper looked at a result from breast cancer screening, and it shows the women in the intervention group had significantly higher odds of being up to date on mammography screening at the end of the follow-up period compared to women in the control groups. And the effect of the intervention was stronger among women who were not up to date with breast cancer screening at enrollment. So they show improvement and effectiveness from the navigation strategy. I also want to take this opportunity to share a trial my colleague and I recently completed. It's called 5 Plus Nuts and Beans. And it was a dietary intervention in urban African Americans. 5 Plus Nuts and Beans was an 8-week randomized clinical trial with 123 African Americans with control hypertension from an urban primary care clinic in Baltimore, which is East Baltimore Medical Center. And the trial was implemented in partnership with Community Supermarket and Baltimore City Health Department. And participants in the active intervention group, we call it DASH Plus, received coach-directed dietary advice and assistance with weekly online ordering and purchase of a high potassium food with a budget of $30 per week and delivered by a community supermarket to a neighborhood library, which is an Ankle Prague library on the Orleans Street. And participants in the control group, on the other hand, also receive a printed DASH diet brochure plus a debit account of equivalent value to that of DASH Plus group. So also $30 per week's budget, but they can go to the supermarket to buy whatever they want, but food only, not other things. So this shows we partner with a supermarket called Santoni in Allentown, and this is our bus driver. This is our coach, and this is a participant. Participant pick up the food from the library. This is another coach with another participant, and Debbie, our coach, was in this health fair to show what's a 5+ nuts being food for the participants. So the result from 5+ nuts and bean trial shows compare with the DASH group, the control group, the DASH plus group, the intervention increased self-reported consumption of fruits and vegetables, increased estimated intake of potassium, and increased urine potassium excretion. This is a measured outcome, but no significant effect on blood pressures. um, the point to show the example of 5+ nuts and bean, it's not 5+ is not related to diabetes or cancer directly, but this type of intervention for minority group in a community-based study, I think it's interesting and important, and I would like to do continue this type of research in other cancer-related areas. So let me switch the topic to metformin and cancer risk. There are many different diabetes medication out there, and there are several of them being linked to increase or decrease cancer risk. And today I'm going to focus on metformin only. So metformin is an oral biguanide anti-hyperglycemic agent commonly prescribed to treat early type 2 diabetes, which is like a first-line treatment for people with diabetes. So metformin lowers glucose by inhibiting glucose production in liver. Okay. So this is metformin. It can act in liver and to lower the glucose and maybe the insulin levels. And on the other hand, metformin in the preclinical data show it inhibits cell proliferation, reduces colony formation, and prevent tumor development. So metformin can directly work in breast cancer cells through these AMPK pathways, and it may inhibit the cell growth and proliferation in the cell level. So the first metformin cancer study in human was, or I should say, well done. Well done. No, these are human studies. Was published in 2005, and this study shows ever exposed to metformin reduce the risk of cancers. And the study actually demonstrate the dose response associated with total prescription of metformin and total milligram dispense with metformin. So metformin looked promising in those early studies. And after that, a lot of studies look at their data and found and reported metformin reduce the risk of cancer. So this is one of the meta-analysis published in 2012, not long ago, and shows several studies here has reduced cancer mortality as well as cancer incidence in several of the studies. And the combined risk is below 1, significant. And this meta-analysis also show protective effect from metformin on cancer-specific type, like colorectal cancer with a relative risk 0.68, liver cancer very significant 0.2, and lung cancer 0.67. So it looked very promising. Maybe we can use metformin as a cancer prevention, right? Okay, so after that, several epidemiologists started to examine the methodology limitations rigorously in those earlier studies. When I say earlier study, that means study published before 2012. That's not very long ago. And I call the study as a first generation observational study. So what are the major limitations epidemiologists found. The first is called confounding by indication. I think most of you know about this. So metformin is used as a first-line treatment and usually initiated in patients who are at early stage of diabetes. So, and other diabetes medication are usually prescribed if metformin is not tolerated or contraindicated, like older age or low kidney function, or if metformin is not sufficient for glycemic control, so they have to switch to another drug. So in general, compare metformin to non-metformin group is not comparable. They are different in terms of baseline characteristics. Other set of bias called time-related biases, and I can talk about this for an hour, so I'm going to just briefly introduce them here. So the first type of time-related bias is prevalent user bias. So prevalent metformin users are actually survivors of the early phase of therapy and therefore constitute a survival cohort. So metformin group is a selected population. And the second type of time-related bias is called time window bias. It's usually in case control studies. So in case control studies, when duration of time for exposure differ by cases and controls, if the study did not match the follow-up time or did not adjust for follow-up time, the time window bias will occur. And the third type of bias, which is really complicated, called immortal time bias. I didn't invent this. There's a lot of literature on this. So it's immortal time bias is a special case of exposure misclassification. And immortal time, what's immortal time? Is referred to an initial follow-up time during which the cancer could have not occurred due to the definition of exposures. So let me spend like 3 minutes to talk about immortal time bias. So this is a hypothetical example showing appropriate exclusion of immortal person times. Okay, so we use the blue represent an exposed person time. So for example, other medication like sulfonylurea, another type of diabetes medication, also first line, and use the red to represent exposed person time. That's like, for example, metformin use. Okay, so in the first case, this person start with sulfonylurea and switch to metformin and develop cancer in the end. The second case and third case also started with sulfonylurea, switched to metformin, but in the bottom panel, all three of those cases were like treated with sulfonylurea, no metformin, right? So when we calculate incidence rate for metformin group, this inappropriate method will just count. Okay, the number event is 1 here, which is correct. One case developed. And what's the total person time? It's they add up all the metformin time. Oh, I'm sorry, it's correct. So 1 divided by 9.8 is incidence rate is 0.102 in people exposed to metformin. In people did not exposed to metformin, the event is 2 here, 1 and 2 cases, divided by all the person time add up in this group. And they found the incidence rate is 0.12. So if you take the ratio, you'll find the relative ratio is 0.885. Look, metformin worked really good. And what's the problem here is this. It's okay, the metformin group, incidence in metformin group is calculated correctly. However, in the control group, the person time here should be included in the denominator as the person time exposed to sulfonylurea. So if you do the recalculation, the relative ratio will be 1.55. So it's go to the other direction. So this is a hypothetical and simplified example. It shows the immortal time bias can lead to incorrect conclusion in terms of not just metformin, but maybe other medication in pharmacoepidemiology. We should re-examine the methodologies. So what's the solutions? There's expert suggest doing like using new user design instead of prevalent users, and we should have proper comparison group, maybe matching propensity score matching in certain variables, do time variance analysis, and do and consider cumulative dosage. And so start about like a 2014 more study, better done studies start to show up. I call them as second generation cohort studies. And this is a publication by another Hopkins graduate. He looked at association, has a ratio for the association between initiator of metformin monotherapy and initiator of sulfonylurea monotherapy and cancer risk using used a large UK database. And he did not see any significant protection effect from metformin on cancer incidence. So the conclusion for me is we should hold on the clinical trials of metformin as a primary prevention for cancer, and don't add metformin into water to prevent cancer at this moment. But this sounds very discouraging, right? So, okay, before I switch to different topic. So in addition to those biases, there are other challenges in methodology. So we still have limited power to detect modest association, particularly for site-specific cancers. And most diabetes patients were treated with one or more medication. It's difficult to assess independent associations. And the association can be confounded by a major or incomplete major risk factor like A1C or obesity. So ADA and ACS consensus panel has another recommendation before we even know about all those biases. They say for most diabetic patients, cancer risk should not be a major factor in choosing anti-diabetic treatment. They are correct. So come back to metformin and cancer. So remember, metformin can work directly in tumor cells through the AMPK pathway. So hundreds of clinical trials are ongoing right now to look at whether metformin improve cancer outcome and reduce cancer recurrence or inhibit tumor growth. A lot of them, like more than 100 currently. And one of the large trial is ongoing in breast cancer progressions. It's a multi-country trial with more than 3,000 breast cancer patients who were receiving standard therapy for their breast. And they use a metformin 850 milligram versus placebo for 5 years. These are very long-term trials. They exclude people with diabetes, older age, or have a heart, liver, or kidney dysfunctions. The primary outcome for this large trial is invasive disease-free survivals. And secondary outcome, they are going to look at overall and distance disease-free survivals, breast cancer specific survival, as well as adverse event and quality of life. And I know the trial already finished the patient recruitment and intervention is ongoing. I think we'll hear about the result in a couple years, maybe 3. Okay, so next topic I want to talk about weight loss and cancer outcomes. So meta-analysis already been shown increased BMI, body mass index, associated with many increased risk of many cancers. This is in men, and similarly, this is in men. And the question here is, what if obesity increase the risk of cancer development? whether weight loss can reduce the risk of cancer, right? So this was a classic study done in a Swedish obesity subject study called SOS. And in their 2007 first publication, they found 38% reduction in risk of cancer deaths. Oh, I'm sorry. SOS it's including 2,000 obese adults who underwent bariatric surgery, so who lost a lot of weight, and compared to another 2,000 matched control. This is not a clinical trial, it's an observational study. So in this first publication, they saw reduction in cancer risk, but the number was quite small. And so later on, they update their result and in 2009, and they found a significant the weight loss. The surgery is associated with reduced cancer mortality in women only, not in men. Okay, so next step they want to look at whether the magnitude of weight loss matter in terms of cancer risk. So they did a separate analysis in women by their intervention group. It's surgery or control. But in the surgery group, there's a weight change tertile 1, 2, and 3. But they found the cumulative cancer incidence was the highest in the highest weight change tertile compared to the other two tertiles. And in the control group is the second tertiles. So it doesn't seem there is a dose response, and it's not consistent with their original hypothesis. So their conclusion are SOS study show a reduced cancer risk from bariatric surgery, particularly in women. But the beneficial effect of bariatric surgery on cancer may be mediated by mechanisms other than weight loss alone or by reduced energy intake. There may be another biological pathways they did not study, and it's contribute to the cancer reductions. So I'm involved in another trial called Look Ahead study. And Look Ahead is a multi-center randomized clinical trial examining the long-term effect of an intensive lifestyle intervention program on CVD mobility and mortality in overweight or obese person with type 2 diabetes. And the sample size is more than 5,000. So over the 10 years of follow-up, compared to this is the red line is the control group, and the blue line is the intervention group. The intervention group shows a significant weight loss in the first year, regain a little bit, but always significantly lower than the comparison group. However, after 10 years of intervention, the main result did not show any significant difference in terms of CVD mortality and morbidity. So Look Ahead study uniquely, it's a unique aspect of Look Ahead studies. We actually adjudicate cancer outcomes, and we are looking at the data right now, and hopefully we'll have a report to everyone like in a year or so. This is another exciting opportunity for collaboration. Okay, so about a couple of weeks ago, ASCO, American Society of Clinical Oncology, actually has a report about weight loss and cancer outcomes. And what they stated is currently no data that provide definite evidence that weight loss, caloric restriction, or increased exercise will prevent cancer or lower the risk of cancer-specific mortality. However, hundreds of small trials in patients with cancer, so cancer survivors, are evaluating the feasibility and benefits of weight loss and physical activity intervention with regard to intermediate endpoints and patient-reported outcomes. But most of those trials focus on patients with early-stage breast cancers. And these trials have demonstrated that weight loss and physical activity intervention are feasible in cancer survivors, and they can lead to improvement in outcomes such as body composition, physical fitness, body image, fatigue, quality of life, and biomarkers linked to cancer outcomes. And in the same paper, they made recommendation about obesity clinical trials in cancer survivors. And this is really related to my ongoing trial I'm going to talk about after this. So the first recommendation they say is conduct large-scale randomized trial to test impact of lifestyle change on disease outcomes. They even say the research team should include a multidisciplinary team of researchers with expertise in oncology, clinical trial, behavioral science, weight management, nutrition, and physical activity. And a target patient population should be those with most existing evidence and largest group of cancer survivors. Study design should ensure adequate power to detect biological plausible effect size, must take into account improvement in cancer prognosis, must enroll patients with sufficient risk of recurrence. They recommend the endpoint can include cancer outcomes, comorbidity, feasibility of implementation, economic endpoints, and intermediate biomarkers. They also emphasize a concomitant dissemination, translation, and other research in cancer survivors. So we do the study in academia setting, but we have to aim to translate our finding to community and the real world population. So this is what they recommend is really close to what I'm doing. It's called SPIRIT trial. SPIRIT stands for Survivorship Promotion in Reducing IGF-1 trial. And it's a randomized clinical trial of behavioral weight loss and metformin treatment to lower insulin growth factor in cancer survivors. And I'm the PI for the study, and Dr. Larry Apple in Welch Center and Dr. Mike Garducci in Oncology are my co-PIs. And this trial is funded by Maryland Cigarette Restitution Funds. So we do have a team of multidisciplinary team of researchers in this clinical trial, including oncologists, behavioral scientists, nutrition, and clinical trialists. So briefly about IGF and cancer again. So I showed this diagram early on. I'm not going to repeat this again. And in literature, the higher IGF associated with higher incidence of some cancers and survival in cancer patients. So the hypothesis is reducing IGF might prevent cancer in patients without cancer and cancer recurrence in cancer survivors. How about weight and IGF? The association between weight loss, and IGF-1 is not clear. So some cross-sectional study look at cross-sectional weight and IGF shows a reverse U shape. So people with a low BMI and high BMI has lower IGF level. That's in some cross-sectional study. But some other RCT randomized clinical trials show higher physical activities level associated with lower IGF-1 level in breast cancer survivors, and reduction in caloric intake with substantial weight loss, also lower IGF-1 in some of the studies. How about metformin and IGF? I talked about metformin already. So in literature, metformin decreased IGF-1 and other growth factor in preclinical and small short-term human studies. So those studies include patients with diabetes or patients with endometrial cancer or polycystic ovarian syndrome or in healthy men. Small studies. And so the objective of the SPIRIT trial is to compare the effect of self-directed weight loss, coach-directed weight loss, and metformin treatment on IGF-1 and the IGF-1 to IGF-BP3 ratio. The primary aim is to test the hypothesis that participants in the coach-directed behavioral weight loss arm will experience greater decrease in IGF-1 and IGF-1 to IGF-BP3 ratio than those in the self-directed weight loss arm. And the second aim is to compare people in the metformin arm to the people in the self-directed arm. We have a lot of secondary aims that includes compare metformin to lifestyle intervention, and we also want to compare the effect at 12 months. So primary endpoint is 6 months, secondary endpoint is 12 months. And we're also going to look at the data on weight, BMI, quality of life, diet, physical activity, glucose, insulin, A1C, inflammation marker, and side effect. And we will conduct pre-specified subgroup analysis on sex, race, type of cancer, baseline IGF-1 levels. In the study, we collect and store specimen of blood and stool for other assays. So who are our study participants? So the participants in the SPIRIT trials are cancer survivors, and those they are persons who self-report a malignant solid tumor diagnosis and have completed curative intent treatment and have no ongoing or planned active treatment except chemoprophylaxis, like the chemotherapies. And we aim to recruit, randomize 120 participants with 40 each arm. Eligibility are determined by the series of web, phone, and in-person contacts. And men and women of all races and ethnic groups are eligible to participate in this trial. But we aim to enroll 50% of men, 50% of men, and 50% of African Americans. So this is a summary of the study designs of 3-arm trial, self-directed weight loss, coach-directed behavioral weight loss, and metformin. Data collection occur at baseline, at screening baseline, 3 months, 6 months, and 12 months. And for the coach-directed behavioral weight loss, I mentioned we use the program called Energy, and it's delivered by coach through website and phone. There is no face-to-face personal group or group sessions. So Energy program is a collaboration with Healthways, and it's based on a successful remote arm of the POWER trial. And Healthway made it commercially available to health plans, employee, and managed care organizations. So this is some screenshot from the SPIRIT intervention website. This is a fake patient, non-adherent. So he started with weight 241 pounds, but still after 160 weeks, it's still 241 pounds. So this is for this is a bad, this is non-adherent participant, but this is the screen they will see and to keep track of their weight, as well as diet and physical activities. And at the same time, the coach is able to see the summary in terms of weight, food, and activity for each participant. And metformin treatment, we obtain IND waiver from FDA's, and we are doing oral titration starting with 500 milligram per day and for 7 days, with breakfast for 7 days or longer if needed tolerance, and well up to 2,000 per day if tolerate. So the recruitment, we use a multi-channel strategy, and we started with a huge list of commercially available list of cancer survivors, and eventually we will be recruiting patients from primary care setting and perhaps from oncology center, and we are testing out online recruitment as well, but those are pending in terms of IRB approval with other strategies. And all the enrollment and data collection were done in ProHealth, which is in Baltimore County in the Woodlawn area, not in our hospital. As of today, so we start randomization last month in August, and as of today, we randomized 13 participants. And I think our pipeline is strong. So what's my future studies? So I'm very interested in collaborating with colleagues on molecular study in the obesity, diabetes, and cancer. So I mentioned about in Spirit trial, we collect specimens, and in look-ahead study, also specimens are available. And those are good opportunities for biological-oriented research. And I also want to develop a guideline to evaluate the study quality for those using electronic or medical record data. So this is inspired by the metformin and cancer studies in the past few years. I'm also very passionate about community-based and health system-based intervention study. So like community-based cancer screening, community-based dietary interventions. And I'm involved in some analysis of using large data from our healthcare systems. They are not cancer specific, but I see a lot of potential using large data in cancer prevention and controls. I want to end my talk with circle back with Mr. B. So Mr. B actually is seeing his nephrologist about his chronic kidney disease. He has stage 4 chronic kidney disease and need dialysis. So that's a new challenge to his life, on top of the history of type 2 diabetes and cancer and other heart conditions. So the example like this remind me the epidemiology to think beyond the data I'm looking every day. So Mr. B is a record in my data set, but he is a real person. So the prevention of diabetes and cancer should be done, and it can be done in the community level, in the population level, and in the healthcare system level, and it should be done like that way. Okay, so finally, I want to thank my colleagues. First, Dr. Fred Brancati, who passed away 2 years ago. Fred and I started the whole diabetes and cancer research, and he would have been happy about the Spirit trial if he was still around. Dr. Genevieve Matanowski is my thesis advisor in the PhD program, and Dr. Larry Apple, the director in Welch Center, and my colleague in Welch Center in epidemiology and in oncology. Of course, my Spirit team, as well as Maryland Cigarette Restitution Fund for my research. Thank you for your attention. Thank you.
Developing cancer if you've had a longer period of kind of a diabetic foundation to promote cancer development? Do we have any sense of the timing related issues?
Oh, that's a great question. And actually, you raise a question about potential reverse causality between the diabetes and cancer associations. In several studies, the association between diabetes and cancer are stronger during like only couple years before cancer development, right? So, but we know cancer will not be diagnosed shortly, and it develop over a long time. There is a possibility is a reverse causality. Maybe there is already a cancer developed and diabetes diagnosed. We don't know. So a good example is that pancreatic cancer. So pancreatic cancer and diabetes tie together and strongly. And maybe people with pancreatic cancer after surgery, they have diabetes, and they're all related to pancreas. So that's a good question. And in like a data from Eric's study from from CLUE study were set up for so CLUE study were set up for cancer outcomes, and so they adjudicate cancer outcomes. Follow up cancer outcomes nicely. However, they did not plan to study cardiovascular risk factors at the beginning of study. So participants were not fasting at the baseline. And like Eric's study was set up for CVD outcome, they did not plan for cancer outcome at the beginning, and the sample size is about 16,000 people, but for cancer studies still relatively small. So I think the future and what people are doing now is combine data from different cohorts, and we'll have more data to look at more specific biological mechanism. Yeah, thank you.
Thank you. So my question is just how strong do you think the observed correlation would have to be between metformin and a reduced risk in cancer for that to play into doctors' decision making when deciding which diabetes treatment to use?
Okay, so the standard, so that metformin is a first line of treatment, and it's been around for decades, maybe more than 30 years, and that will be related to and the benefit of metformin is it's safe, it's not a lot of side effect, and it's really cheap. It's like 4 cents per pill, and it's really hard to make a clinical recommendation if for cancer prevention purpose, risk purpose. So in general, the risk of developing cancer is relatively small, even in people with diabetes and take metformin or other insulin or other medications. Yeah.
So we had a slide up earlier where it looked at the different groupings with bariatric surgery. It seemed like the ones who had the most amount of weight loss it didn't really correlate, right? It seemed like they might have been
No,
higher.
yeah. So that's from the SOS study here, right? So in the first analysis, they show bariatric surgery in women has a reduced risk. So where is the cursor? Okay. So the cancer incidence in the control group is higher than the intervention group, in the bariatric surgery group. But when they look at the magnitude of weight loss from surgery, they did not see the dose response. It's like opposite way. The one with the most weight loss has the highest incidence of developing cancer, but it's still small sample size. Yes, go ahead. Mm-hmm.
If you weigh more for a longer period of time, you have more chronic inflammation and more chance of developing cancer anyway. So
yes.
Is that a possibility that those people in that who lost the most amount of weight were the ones who were more obese to start with compared to the other groups?
Yeah, I think that's a good observation, and it certainly explains some of the difference. Like as people started with more higher weight, tend to lose more weight after bariatric surgery. Yeah, so but they also represent a population have a longer exposure to the obesity. Yes. This is it's not a clinical trial setting. So how comparable between the case and well matched control biologically, it has to be investigated further.
So Jessica, the state of Maryland is going to release a new cancer plan in the next 6 months.
Mm-hmm.
What would you recommend in terms of cancer prevention?
Oh, this is a very serious question. So I think the cancer prevention should still focus on the lifestyle prevention. So I think prevent diabetes, prevent obesity, prevent cancer, that can be done together. And for cancer prevention, it can be smoking cessation, weight loss. That's still, I think, it will be still very, very important on the list. I would not recommend any pharmaco approach for cancer prevention purpose alone.
But there is a wide range of behaviors that could be addressed.
Yes, exactly. So obesity related to physical inactivity, related to dietary unhealthy diet. So each of those components can be different intervention, and what's the audience of intervention will have to adapt for different space, more individualized for different population.
Well, thanks so much. Well, let's give Jessica a hand. I really appreciate
Thank you.
coming.